fracture. We've got the C-arm coming in tight to the table from the bottom. We use the surface of the C-arm as our operating surface, and we have the monitor straight across the table so we can look through the C-arm at our monitor. I gently secure the head. We move the patient way over to the side of the bed. She's an 8-year-old, so there's quite a bit of room, but in a 2-year-old, it gets pretty tight. So we just put a blue towel here, some tape, so that as we're tugging on the arm during the reduction maneuver, we don't dislodge the tube and move the head off the bed. So this fracture is laterally displaced, so we first correct the medial lateral displacement. Generally grab the arm with my fingers and then push on the fragment with my thumb. So first correct the medial lateral displacement. Okay, and x-ray, so that's better. The closed reduction prior to prepping and draping, it's generally easier to do the reduction here first, just like if you're doing your closed iron nailing of a femur, for example. Make sure you can get out the images and make sure that you can achieve your reduction. If you can't, then you know at this point you need to do an open reduction, and so you can get that table set up. But right now all we have open is a supracondylar pan. We don't have a cautery pad, we don't have electric cautery setup, we don't have suction or anything else set up. Okay? So the assisting surgeon holds the elbow in about 30 degrees of flexion, while the operating surgeon places one thumb posteriorly behind the lateral column, one thumb posteriorly behind the medial column, almost getting under the fracture, and then we're going to push it distally as well as anteriorly wide, hyperflex the elbow. Okay? Go ahead, yeah, just hold. Right. Yeah. Got it? And then we'll check our image. And it looks nearly anatomically reduced. So then I'll check the medial column, x-ray. That looks very good. Maybe off just a little bit. And we'll check the lateral column. And again, it looks awfully good. So I know that we're going to be able to get a closed reduction, so we don't need to open, and now we can prep and drape. So draping then is very easy. We just put a down sheet. Then straight to the extremity drape. Maybe you clamp this up. We don't need a bar necessarily, but if you can clamp it, that would be great. Got it? Yep. And somewhere over there, that would be terrific. C-arm drape. And the C-arm is just draped into the field. We don't have it so that we don't need to move it in or out. We just keep it stationary. Pull that up as high as we can. Yep, I got this one. Great. And then the split sheet. And that's it for draping. The fracture is displaced laterally again as we anticipate, so we just correct the medial lateral displacement. And when you're ready, okay, all right. Terrific. And x-ray. So again, looks like we're very well aligned x-ray. Great. Check the medial column, x-ray. That looks very good. Lateral column, x-ray. That also looks great. So we're good to go. And you can pin the medial side or the lateral side. Some people use 2 or 3 lateral pins. Some people use 2 lateral and 1 medial. I tend to use 2 lateral and 1 medial. In the biomechanical studies, that seems to be the strongest construct, but it means you're placing a medial pin where the ulnar nerve is at slight increased risk. So We're identifying where the medial epicondyle is, and she's pretty swollen, so I'm going to make just a tiny incision with a 15 blade, and we'll use a mosquito clamp to hold the ulnar nerve out of harm's way. Okay. So once you make that small 4 or 5 millimeter incision, the tension of the incision's gone, and you can easily palpate the medial epicondyle with the mosquito clamp. So I have a mosquito clamp on the medial epicondyle, gently draw that posteriorly, so I know I've got the ulnar nerve out of harm's way. Take my 0.62K wire, check it with fluoro, X-ray. Okay. The medial epicondyle pin, the medial epicondyle is situated slightly posteriorly, so that pin goes slightly posterior to anterior. X-ray. Great. Can we have a pin cover, please? And so identify a starting point for the lateral pins. Just check an X-ray with a sucker tip confirming that the lateral condyle is a little bit anterior to the shaft compared to the epicondyle, which is a little bit posterior. Medial epicondyle is a little bit posterior. Okay, ready? Okay, so we're going to place 2 lateral pins. Our first one's going to be more transverse, and they're going to be divergent. So go ahead. Keep going. You should get across the far cortex. Perfect. That's the far cortex. Yep. Now we'll take our second pin, and I typically place the puncture immediately adjacent to our first pin, so just put it next to it and slightly posterior. Yeah. So that's it. Yeah. Great. Okay. And now just look at your pins outside the skin. That's going to be how divergent they are inside the pin. So you're going to bring your hands anterior a little bit, but still keep them divergent. So that's it. Yep. Okay. And yep. Perfect. Let's just see what that looks like on C-arm. X-ray. Great. So that looks terrific. Yep. Go ahead. Great. Yeah, I think you're probably right. X-ray? Yeah, so that's going to be great though. Just a second, yeah, just stop. We'll just see where it is. We may be, obviously, with your anterior or posterior. X-ray? So we've got our 3 pins. We need to engage the far cortex with all of them. And then we just check an AP X-ray, and they look great.
It's going.
Okay, we bend the pins externally. For the single medial pin, we can use the magic pliers. And we have the pin cutter. I leave about 7 millimeters of the pin distal to the bend. And then pin cover. Now I hold the pin so I don't dislodge it while I'm placing the cover. Okay, go to the lateral side. Yeah, great. The lateral side, because we have 2 pins, we can't use the magic pliers to do the bending, so we'll take a small sucker tip, which is in the supracondylar pinning pan, and bend it over the magic pliers. And we'll take the pin cutter. And we'll do it to the other pin. Lift up a little bit there, David. Yeah. And a little bit more. Okay, pin cutter. And needle holder. I leave, again, a good centimeter outside the skin and bend it 90 degrees so there's no way the pin can work itself. Got a pin cutter, please? Or pin cover, excuse me. So there's no way the pins can work themselves underneath the surface of the skin. Right? And you can, so this liafoam sponge comes with the supracondylar pinning case card. So I just cut a small square from it. Cut a small slot in. Not too deep. And then just slide it under the pin. And that little medial incision I made, I don't put a stitch in it or anything. I just cover it with a liafoam. Okay. Let's go to the lateral side. Yep. Take another liafoam, please. Just fold it in half. Okay, thank you. Go. And that prevents the pin or the skin from pistoning up and down in the skin, and we just don't seem to have a problems with pin sites. And then after doing all that, I'll take final images for Q reads. So AP, please. Great, can you send that for Q reads? And then the lateral. So I like to put a cast on instead of a splint. Would you put a hand behind the elbow just to support underneath there? Great. Great. Now with your right hand, you're going to grab the thumb. Okay. Good. And yep, your left hand, you can grab the hand. And we've got the thumb skin only. Slide that down. And just the fingers down. Okay. And like this and flex it. So generally flex a little bit under 90 degrees. So 80 or so degrees of flexion is just fine. And I just put the stockinette right over the inside and live. Cut out the stockinette and Google fossa. Pins. And looks great. Okay. And we're going to bivalve the cast. So I can put on a reasonably snug cast knowing that we're going to bivalve it to loosen it. So I wrap ulnar to radius. Relatively low in the hand. We're not going to include the thumb, but I found if you go around the base of the thumb, that pads it up very nicely.
Good. Yeah, reverse.
And then up the edges.
Oh, she did on her own. Yes, I
And
knew.
really flex it a little bit, bring it down. Okay.
Listen, it was like squeeze pretty good. Do you have an algorithm for hypoxia? Well, how do you start here? Yeah, I was like, and I looked at it, and do the
When I get to the elbow, I find that consecutive flaps don't work as well as hitting the tip of the electronon,
Yeah.
and then coming back and getting that spot.
Right, right. But it's nice that she.
I entered the regional force,
Okay.
so don't do it again. It's all set.
And I don't think-
We had to do a test. She's fine.
Oh, yeah. And when she said her hip pain went away, I think that
Oh, yeah.
it
The
was
problem
And
is,
above the elbow, you can wrap it down fairly snugly. This area is never a problem with swelling or cast tightness. The cast will be loose up here.
Let me check and see if practice here, so we can do that.
I know we do a lot of spinal issue, but 25 gauge, the CSF return is so slow and miss it, kind of like an IV, you go from faster normally.
Sure.
And so
A
I
little extra pin size.
follow the CSF,
Elbow.
pull it back, and you're good. The problem is, you know, her back is strong. We can't really make these better as well.
Right, and so we don't want them to be, if we're going to bivalve it, it doesn't have to be bulky to accommodate swelling.
I would forgot to give up.
So 3 or 4 or 4 or 5 behind the elbow, but 2 or 3 in the forearm. Come to the antecubital fossa and I pull out all of the calf padding that's right in the fossa. So I know that right in the antecubital fossa there's no calf padding bunched up. And I put just a last little piece over the top so we know there's no cast material right against the skin. And finally, around the end of the cast, fold one. So 2-inch, anchor it in the forearm. Yep, that works great. Cut along the radial border of the index finger. Cut it once. Next time through, spin it to reinforce the first web space so that it's stronger and doesn't break. And cover it up. Another split roll. Catch the corners as you come around. And then up the arm. And I don't have a lot of tension, just the right amount. And then you get to the elbow, tip of the olecranon, come back and get that spot, and then go right above, and up the rest of the arm, and again above the elbow you can use just a little bit more tension. Back of the elbow is always a thin spot. So with the second roll, I reinforce that area. You can do it while you're rolling, but I find for me it's easier to do just to layer it back and forth a little bit as you start your second roll. Okay. That's just a little bit perfect. Top. 2 or 3 rolls around at the top. And we just a single roll of casting material tends to create kind of a sharp edge.
Yeah, it is.
So Pat, we say we just have to call before we're leaving.
Oh, yeah, sweet. I just reverse her. She had twitched back.
Perfect. How
Back
many?
down there.
Perfect. That's a nice dose, that
Yeah.
intermediate.
Cover up our reinforcement. I like to just cut a little hole for the thumb again. Smaller hole than you would think. Pull that over the thumb. Around the top.
So they're okay downstairs with that neuroradiologist?
I remember from Brian, he was called to say that they were in CT that, so
Okay.
I give him a call.
Okay.
John, I'm just asking.
Just short of 90.
No, I'm sure.
Do you know what it has to do with
I
it?
hope he was like,
And then the last roll will be a 3-inch. Like a somewhat sloppy wet.
That's
Anchor it in the forearm. Radial border of the index finger. And we're going to be overwrapping this cast later, so we don't need to make it too
Is there anything I should do, or?
Okay,
thick or heavy now.
The problem is our spinal kids aren't really spinal kids, they're saying there's no way to produce her needle. Which is like having a laser.
Sounds good.
What he did was.
So we improvised, we got a separate 25 feet.
Yeah.
And then that 51 goes.
they're on the table, they're in there, and he's all
Well, they're using it.
Okay.
Oh,
And I don't know if Dr. Hummerus, we typically get those medically undirected.
yeah, I mentioned that to him.
I mean, just in terms of the table. Yeah.
I know that case, I looked at it, it's listed for 3 hours, I don't know why I take that long, but it's fine.
Oh,
And I mold the back of the distal humerus flat, right? The distal humerus goes flat. So I want the back here to be flat. Of course, with an extension type fracture, that's the direction the fracture was displaced. So we want to resist any tendency
oh,
to
that's
redisplace and extension.
antibiotics, yeah.
And then anteriorly, I try to mold around the condyles.
Forget it. We use the regional green anesthesia.
Point mold, like a drill chuck,
Oh, well.
molding around the medial and lateral condyles.
Yeah, you do a lot of spinals in OB though.
Yep. Then
And their kids have an
Mr. Potter insists we put a puppy on.
Yeah, nice.
Wrapped up with our
And
A-strap.
that's a bit, I mean, well, probably the reason we don't have a real kid here is because we just don't do spinals. Although it gets to be a self-fulfilling prophecy. Because the kid is poor, nobody wants to do spinals, right?
Find out the cast. I like to make straight cuts. Here we cut straight through the puppy dog. And then you're punching straight in. You're not dragging it along the surface. Just punching straight in. Especially at the ends where the casting material is underneath the stockinette. Use your thumb on the cast to brace it so that you're not plunging, but you should move relatively quickly so that you're generating as little heat as possible. Okay, you can stop there. So we do the same thing on the molar surface, bivalving it all the way up. Making sure that you get the casting material underneath the stockinette at the end. Then spread it apart a couple of millimeters so that we know we've got space available, and spreading it apart at the ends again so you know you've gotten all the casting material underneath the surface of the, or underneath the stockinette. You want to grab that?
So our aim line had come out of failing on that.
And I like using adhesive tape instead of A-strap. Oftentimes an A-strap, if you overwrap it, it's just as tight as if you didn't bivalve the cast. So we're actually kind of using the adhesive tape to hold the cast open.
Yeah. You know, speaking of kits, that's the other thing. I don't know if they make them anymore, but Arrow
So I'm really just laying the tape on.
Arrow wire, and it came in its own package
Okay.
in a U shape. And it was big
I
enough
usually do
to
two in the forearm.
IV to just barely, so it was pretty thick. And if you had pulsable flow, you couldn't thread and that sort of thing. It was beautiful. We just couldn't.
There are wrinkles, but just ignore them.
I'm not at this hospital where I can preemptively, we go soon to intentionally pull back.
And then one above the elbow.
Wiring. It's a great rescue. The problem is we don't really have a good wire here to rescue in our line with. The ones that are there are pretty incorporated or so thin that they don't, they're kind of hard to follow. But I don't know if Arrow makes those or not anymore, but they were very, very handy. Just the little things like that.
All right,